Thank you, Liana, for nice words, and it's a real pleasure and honor for me to be here with you. And thank you, Lars, Lars and the other organizers for inviting me. So it's a long question, and my first slide is just an extraction from the abstract. So saying that major improvements have occurred in the management of inflammatory rheumatic joint diseases, whereas progress has been more limited in soft tissue conditions, low back pain, pain syndromes, and osteoarthritis. That's at least my interpretation, if I should try to make some sort of a summary of what happened from 2000 to 2010 in rheumatology. Saying that means that I will also have my strongest focus in this talk on inflammatory rheumatic joint diseases. And I think that the main elements in the advances that we have achieved over the last 10 years, that is about early diagnosis, it's about early use of disease-modifying treatments, and it's about thinking of how we can prevent various outcomes in individual patients. So you see here, I have not included actually the biological agents here. Of course, the biological agents, they are extremely important. But if we have a global perspective in our thinking, then of course the biological agents is less important than having effective strategies which not necessarily are very expensive. So that's why I'm also going to focus more on strategic thinking, which has been more and more important over the last years. And the key element in this strategy thinking is that we are focusing in inflammatory joint diseases on 3 different dimensions. It's the inflammatory activity, the inflammation, which is driving the process of joint damage. You have heard about that also earlier today. And it's also early in the disease, the inflammatory activity, which is most strongly related to the functional problems of the patients. But in the late disease, joint damage will also be a driver of disability. So this means that if we have a focus on the inflammatory activity in our treatment, then we will also have the opportunity to prevent the development of joint damage, to reduce the immediate functional consequences of the disease, and also prevent this relationship between joint damage and disability in the future. Up to now, the American classification criteria for rheumatoid arthritis, that was published in 1988 and elaborated in 1987, that has been the existing classification criteria for rheumatoid arthritis. And I think all communities agree that they have not been very useful over the last years, because with the current thinking of preventing radiographic damage, preventing joint damage, of course then it's not logical to have radiographic changes as part of the classification criteria. And also rheumatoid nodule is also a late sign in rheumatoid arthritis, so everyone agreed that these criteria were outdated. The thinking now is more that in the early arthritis clinic, you see a patient with the joint swelling, and when you see this patient with swollen joints, one joint or more joints, then the main question is to try to identify markers or predictors of various disease courses. Because we know some patients, they will have a self-limiting arthritis, some patients, they will have a persisting non-erosive arthritis, and some patients will have a persisting erosive arthritis. And some of this thinking was also behind the first phase in the data-driven process of the elaboration of the new classification criteria of rheumatoid arthritis. And this is the thinking that we are using also in all early arthritis clinics. And early arthritis clinics, that's really an important tool to build collaboration between primary care and rheumatology, and also to receive patients early for diagnostic assessment. So the new classification criteria for rheumatoid arthritis, that was a joint initiative between ACR and EULAR, so that you see this is also an example about collaboration in the world in rheumatology. Very important, several phases. The 2 papers were published simultaneously in Arthritis and Rheumatism and the Annals of Rheumatic Diseases, 10th of August, 2 p.m. British time. That was very politically important that they came out exactly on the same time, of course. So this is the list of the criteria, and the first step is that you identify clinical synovitis. And then you make an assessment whether this clinical synovitis is caused by a specific reason, which is not rheumatoid arthritis. Like, for example, gout, nodocrystal arthropathy, swelling because of osteoarthritis, reactive arthritis. Then it's not rheumatoid arthritis. But if you have an arthritis that you cannot classify, then you go into some sort of scoring system, which is based on step 1, which was the data-driven process, and step 2, which was more a consensus-building process between rheumatologists in US and Europe. And then you have 4 different elements that you are assessing: the distribution and the type of joint involvement, the number of joints and location, large joints versus small joints, etc. The serology, anti-CCP that you heard about earlier today, in the first lecture today actually, or rheumatoid factor, and also not only presence versus absence, but also the level of antibodies. And the third element is the determination of acute phase reactants, presence elevated or not elevated, and duration of symptoms. And if you make a summation of these 4 elements and have a score of 6 or higher, then per definition you have rheumatoid arthritis. So that's the criteria. So these are really elaborated for early diagnosis and of course then early treatment. There have also been work going on in spondyloarthritis, also for early diagnosis. Now the obligatory finding that you needed before, that was radiographic sacroiliitis, and everyone knew that it could take years before the radiographic changes in this sacroiliac joint occurred. So that's why ASAS set up a project to develop new criteria. So now for axial spondyloarthritis, there will also be separate criteria for peripheral spondyloarthritis, which has, I know the paper has been submitted. So, here you can diagnose ankylosing spondylitis or axial spondyloarthritis, which is now the correct terminology actually, sacroiliitis on imaging plus 1 so-called SPA feature, which is listed here, or the combination of HLA-B27 and 2 other SPA features. So the new development here is that you can diagnose axial spondyloarthritis without having imaging abnormalities of the sacroiliac joint, and you can also assess imaging by MRI. So MRI sacroiliitis is sufficient as a sign of abnormality of this joint. So the thinking now is really the earlier the better. And this is an editorial that is really discussing this: when does rheumatoid arthritis start? Because that's another question. Now we have the new criteria, but there are also studies that have indicated that the disease actually starts before, maybe starting before you have joint swelling, because there are at least close association between detection of antibodies and later development of arthritis. So maybe in the future, that was also what we heard in the first lecture today, that treatment will start even in some patients even before you have arthritis. Another major achievement actually over the last bit more than 10 years, but especially 10 years I think, is the development of robust outcome measures. Peter Brooks talked about the UMRACT initiative, which has been extremely important in this regard. And now we have a series of measures that in some way are complementary to each other, and we know that there will also be now a publication rather soon on new remission criteria in rheumatoid arthritis, which is also another joint ACR-EULAR initiative. So the ACR response criteria, they are measuring change. With some of the other composite scores, you measure both a change and you can also measure a state. And that is actually what many people today consider as extremely important, not only to see whether you have an improvement, but that you improve to a certain level. So to look for a state is perhaps more important than to look for a change. So this can be translated into: it's good to be better, but it's better to be good. So that's the important. That was Maxime Dougados, professor of rheumatology in Paris. He was the man writing this in an editorial in the Journal of Rheumatology some years ago. So we have defined levels with these composite scores for emission, low disease activity, and high disease activity, and there will probably be more work to be done. And this leads over to the new strategic thinking about tight control and setting a target for the treatment. So we know from several strategy trials, and this was the first and the most famous, the TICORA study from Glasgow in Britain, where they showed that if you have an intensive and close monitoring of the patients and you have a program of switching therapy if you don't reach a certain level of disease activity, then you achieve a much better result than if you use standard care. So this led to the Treat to Target initiative. We learned from our colleagues handling diabetes, hypertension, hyperlipidemia. There you set targets on blood sugar level, on blood pressure, on lipids. Now we also want to set a target for inflammatory control. And if we don't reach that target, we should intensify our therapy. So that is the idea with the Treat to Target initiative. And this has again then been incorporated in the recent EULAR recommendations for the management of rheumatoid arthritis with synthetic and biological disease-modifying anti-rheumatic drugs, which actually present then an algorithm for what you should do. You should start with methotrexate, you should set a target, and you should monitor the patients closely, maybe as frequent as every month in the early phase of the disease, and switch therapy if you are not reaching that target. Because we know also from data, not only from the first slide that I showed you, that if you are able to suppress the inflammatory activity and reach a level of low disease activity or remission, then we prevent the development of radiographic damage. So in these recommendations, there are 15 recommendations, they are evidence-based, so there are also 5 accompanying papers with systematic literature review. And patients were also involved in these recommendations, so that's also part of the current EULAR strategy, that patients are always involved in the elaboration of such recommendations. Another important aspect in the thinking of diagnosis is, one aspect is to some sort of label the disease. Another aspect is to try to identify predictors of disease course and outcome. And we know that from various research activities that these are candidate variables for prediction of disease course and outcome. And this is just one slide from one of our cohort studies where we looked at a combination of baseline variables with regard to prediction of radiographic progression over time. And you can see here, for example, that with the combination of being a female, being anti-CCP positive, IgM rheumatoid factor positive, elevated ESR, then you have a 90% likelihood of radiographic progression after 10 years. But being a male and these other factors negative, then the likelihood is only 10%. And I think that in the future, we will learn more and more about how we can combine demographic variables, clinical variables, soluble biomarkers, and genetic factors into algorithms that may help us to personalize our therapy. And I think that we also can expect more from imaging modalities, both ultrasonography and MRI. So we know, for example, that bone marrow edema that you see here, there is no erosion here on the baseline, but after 1 year, you have had the development of erosion in the same bone where you saw the bone marrow edema 1 year before. So imaging findings are obviously important. Early treatment with DMARDs is also extremely important, and I'm not going to show you much data on that, but I show you actually slides that you also saw earlier today, but maybe that my interpretation is slightly different. So these are from Dutch randomized controlled clinical trials in patients with undifferentiated arthritis, not reaching the previous RA classification criteria. The patients on methotrexate had a delay in the onset of RA according to the criteria.